I'm live, I think. I imagine. I'm hoping. I'm live. Uh, good afternoon. Technically noon. Good noon. And then thereafter, if you're watching this live. I suppose if you're not watching this live, good evening, good morning, good whenever you're watching. I hope that things are good. Um, Thank you all for watching, attending another here for it live Q&A with Connor. It's me, Connor. I am here for it. Incidentally, um, frequent viewers of here for it are going to know that it is customary for me to give my assessment of the current weather. What is my assessment of the current weather? It's been a nice week. It's been relatively cool. Last week, since there was not a here for it last week, uh, off, hot, terrible. And next week, hot, awful, terrible. So for those of you watching soon, buckle up for what I think is going to be an egregious amount of heat that I frankly do not want in and around me. So you love the heat. Lucky you. This next week's gonna be great. This previous week though, beautiful, awesome, great. It's at least a little bit cooler, so we'll take that. Connor, um, today's Q&A is kind of going to be full of questions recently about care coordination. Um, and I kind of want to go a little bit more into care coordination is because it's probably a term that you are familiar with. It also doesn't like. Let's start off with something to consider. A lot of the terms used in the social services and about these kinds of things are incredibly broad, right? Care coordination is so broad. It's okay. We are going to kind of press on. Uh, um, Care coordination is another sort of auxiliary program that kind of like waivers are an additional program, right? These are auxiliary programs. This is not related to the waiver. I want to be kind of clear on that. So even though there's oftentimes a significant overlap, a lot of people who might be on care coordination, receiving care coordination, might also be on some home and community-based service waiver, right? That does not necessarily need to be the case, particularly with something called MSHO, which we will talk about in a moment. But it's not a like a required combo or anything like that. And so I think sometimes that does confuse people as well. Oftentimes people who are on home and community-based service waivers may also receive care coordination. So, Connor, how do they receive care coordination? Well, there are a couple of programs they can participate in, and they are kind of under. Kind of want to think of it this way: managed care organizations are kind of like I don't know, sort of like health companies, like healthcare provider companies that sometimes take care of part of the programs in non-integrated settings where they might still receive some services from here and some services from here. And then there are integrated MCOs, managed care organizations, and that's where they kind of receive all of their care from a single organization, which makes sense. Healthcare, generally speaking, in recent years, the trend is for things to become more and more vertically integrated, where health plans will kind of own everything from your regular walk-in clinics to your specialty clinics to your pharmacies to the clearinghouses where records are stored, transportation. All of these things are kind of sometimes owned, often more so now, owned by a single healthcare provider, right? The big difference in the kind of option that our folks can receive when it comes to like an MCO and the kind of care coordination or auxiliary program they can receive is based on whether or not they are on Medicare or not. Now, that's not necessarily the only factor. Age is also also the other factor, right? So for MSHO, I promised you, I dangled a carrot. I said, I'm going to talk about MSHO in mere moments. And here's the carrot. MSHO is Minnesota Senior Health Care Options or Health Options. And that is criteria. They are, I think, over the age of 65, if memory is serving me. The second option, the second thing, so along with needing to be over the age of 65, second thing is that they need to be on Medicare Parts A and B. All right. If they are on that, then they can get MSHO. That is where things like pharmacy and drugs, integrated versus non-integrated. It's supposed to be an integrated way of doing this, and so it's all kind of done by a single managed care organization. The benefits that it unlocks are largely similar, but this is one way of administering it. The second way, and this is more common for our clients to be enrolled in, is a program called SNBC, which is Special Needs Basic Care. And in this instance, it's a voluntary service. If you are between the ages of 18 and 64 with a certified disability, you have the option to enroll often in SNBC. They will sometimes send you a letter, okay? And if you're ever working with a client and they get a letter and it's talking about SNBC enrollment, special needs basic care enrollment, that document is going to be a 6451A. And that document is like an enrollment doc. Uh, if they do not answer that and say, I'm okay, I don't need to enroll in this, typically they're oftentimes going to be automatically enrolled. But that's only if they are meeting that letter only gets sent out if they meet all the criteria right away and they're not really going to need to request anything extra to get SNBC. You're going to get that letter. If not, you can still request SNBC. But there's going to be a little bit more of a process to it. There's also technically two different ways that SNBC can be administered. So there is non-integrated SNBC, where there are going to, again, sort of be different providers of potentially different services. So they will receive kind of their MA benefits and then their Medicare benefits from separate entities. They're non-integrated. SNBC-I, you can imagine, probably stands for integrated. And you're right. I imagine all of you in a single voice said, I bet that stands for integrated, integrated. And I heard you, and you're right. It does stand for integrated. It means that anybody who's enrolled in this SNBC program, their medical assistance and Medicare health plan benefits and all of that are administered through the same plan. So something like Health Partners, right, would administer both instead of them being separate, right? And really what care coordination does is it opens you up to an additional support, right? You get a care coordinator, and that care coordinator is employed through that health plan. And the whole idea with them is to, through the lens of healthcare explicitly, support the client in finding new programs and new things to participate in, right? So they're going to do a health risk assessment. So anybody who is a care coordinator, nearly anybody who's a care coordinator, per Minnesota law, also needs to be an assessor. They need to meet sort of the qualifications for being assessor, partly because they're going to be completing this health risk assessment. All right. And what that assessment does is it assesses and looks for what kind of healthcare needs may they have, and how can a care coordinator set up programs to help address those needs. Going to take a sip for those of you who are just listening and not watching. I'm not building suspense. I am thirsty. Oh, that's better. Uh, There are other things, obviously, the care coordinators can do. They're going to also, similar to a case manager, they're going to develop a person-centered sort of care plan for the individuals who are receiving this, taking into account things like preferences and whatnot. They are unlike the waiver, right? So we know when it comes to waivered services and our services and anything kind of relating to the waiver, when somebody's out of community, their waiver closes, right? These services turn off. Since care coordination is kind of done through a care provider, right? A health plan, services like that can continue to they can receive support throughout this. So they can help with things like hospital visits or emergency visits. They can also help plan and prepare and help with services when it comes to kind of like transitional care, transitions into certain care settings and stuff. That is something that a care coordinator is capable of helping with. And that's actually a really important benefit. I think that sometimes when we're working with our clients and they are maybe at risk for a hospitalization or there is an emergency care, I think that it can be tough for us to sort of say, oh well, great, I guess I can't help. And so even though I can't go in and help myself, one of the things I can do if I've got a client who is maybe frequently hospitalized or worried about losing all of their support should they become hospitalized is I can maybe talk to them, have them maybe reach out to their financial worker and start to talk about, hey, could I get on SNBC? Or if I've got a client who's over the age of 65, is this something where I can maybe look at transitioning them onto M Show, right? There is oftentimes weird combos, especially with M Show when it comes to waivered services. So I want to be careful about that. SNBC though is something that we can oftentimes do congruent services with. So it's common to receive a waiver while being on SNBC and then receiving waivered services. So that's I think important to note. Still, I want to help my clients, and sometimes that means advocating and helping them realize that there are some other services and supports that are available to them, and certainly care coordination is one of them. There's an idea of when it comes to care coordination that they are also keeping the whole team involved, right? So when I was a case manager, I worked with care coordinators, right? And we would all kind of work together on coordinating the client's supports and services and what can a care coordinator help with? What can I as kind of a waivered case manager, what can I authorize and help with? Where are there gaps that we can maybe address? And what is nice generally when it comes to working with a care coordinator and a case manager is that oftentimes if all they're receiving is case management, a lot of this health planning stuff can kind of fall on auxiliary workers like us, and we are here to help teach and train and build skills on that, which is excellent. But there are certain times when things get a little bit more intensive and maybe some additional knowledge or support or anything like that could really go a long ways in keeping our clients independent. So care coordination is a really nice way to cover a lot of those concerns, support our clients by teaching and them set up. Care coordinators can help establish health services. So they can help say, hey, if a client says, I need a new primary care physician, a care coordinator can help them navigate that, can help with making appointments or reaching out to physicians, making sure that they're in network and they are someone who can kind of work with that client, right? There